Welcome to the Fibromyalgia Podcast. I'm Tami, fibromyalgia coach, author, and founder of the International Fibromyalgia Coaching Institute. The goal of this podcast is to empower you with access to the dream team of experts and coaches I've discovered are key to living the fibro life you love. From the comfort of your own home, and maybe even your pajamas, I'll help you take back control of your life and health. To help out with FibroFog, I always include full show notes and additional resources at fibromyalgiapodcast.com. You're listening to the Fibromyalgia Podcast with Tami, episode 68. Welcome to the Fibromyalgia Podcast. I'm your coach, Tami. In today's episode, I interviewed Dr. Jessica Drummond about endometriosis, something that I know a lot of you have been diagnosed with. You know, all too often when you're diagnosed with fibromyalgia and experience pain somewhere else in your body, it's just too easy for our doctors to say, well, that's just your fibromyalgia. But many times it's not. My goal with today's episode is twofold. Number one, if you've been diagnosed with endometriosis in addition to fibromyalgia, I want you to hear that you can feel better. As you will hear from Dr. Drummond, endometriosis is very treatable, and she's had great success with many clients. Number two, I want to give you some tools and information that will help you clarify if your pain is from something other than just fibromyalgia. You'll hear the red flags to look for that can indicate your pain may be from endometriosis, not just from fibromyalgia, and what steps to take to make sure you get the right treatment and diagnosis. Of course, before we dive into our interview and today's episode, I've got our listener shout out for you. And this one came through a Facebook message from Erin. And she said, "Hi, Tami. I was diagnosed with fibromyalgia 2 years ago, and my 21-year-old daughter was diagnosed in March after 6 years of debilitating symptoms. I listen to your podcast daily. I just want to thank you. Your voice and experience are so comforting and helpful. I'm grateful to you for everything you're doing. This illness can be so lonely. Please continue your work." So I replied to Erin and I asked if I could use her message as a shout out and also asked if they were both getting the help that they needed. Her daughter actually happens to live in Portland where I used to live. And so I was able to give them some suggestions for good providers in Portland. Erin wrote back and said, "Yes, absolutely. You can use this on an episode. I'm working with a doctor who specializes in fibromyalgia. I'm still trying to piece together what my best life looks like with fibromyalgia, and you're helping me to do that. I'm learning about coaching right now. This disease can be so overwhelming. Coaching just makes sense." Thank you so much, Erin, for sending that back in. And I'm so glad that you and your daughter are getting the help that you need. And for those of you like Erin who may be learning about coaching and thinking that it just makes sense, you can visit findafibrocoach.com or today's show notes at fibromyalgiapodcast.com/68 for today's episode, where you can schedule a consultation with me or one of my coaches. Now, we are also enrolling students in our next training program. If you want to hear from prior graduates on how our Certified Fibromyalgia Advisor program has helped them improve their own fibromyalgia, you can check out episodes 45, 56, or our last episode, episode 67, and we'll have links to all of that in today's show notes, as well as where you can get more information on our Certified Fibromyalgia Advisor training program and how you can enroll. Now, for today's episode, I want to introduce you to my friend, Dr. Jessica Drummond. She is the CEO of the Integrative Women's Health Institute, and she's the best-selling author of 2 books, Outsmart Endometriosis and Clinician to Coach. Dr. Drummond holds licenses in physical therapy and clinical nutrition and is a board-certified health coach. She has 20 years of experience working with women with chronic pelvic pain. She facilitates educational programs for women's health professionals in more than 60 countries globally and leads virtual wellness programs for people with endometriosis. Dr. Drummond has also taught continuing education classes to my coaches on endometriosis. Dr. Drummond lives and works with her husband and daughters between Houston, Texas, and Fairfield, Connecticut. Now, I do need to remind you that while Dr. Drummond is a licensed healthcare provider, she isn't your doctor. Therefore, the information that we're including in this podcast should not be considered medical advice. It's for your education only, nor is it intended to replace you consulting with your own physician or other healthcare provider. If you hear something in this episode that strikes home for you and makes you think that this might be something that's going on with you, we do encourage you to reach out to your doctor or find the right provider for you. Dr. Drummond does list a bunch of various providers and talks about who to find to help if you think you have endometriosis. During this episode, she's going to be sharing several resources to help you if you think you are dealing with endometriosis, and we will have the links to those resources on today's show notes page. We also have the video of my interview with Jessica. So just visit fibromyalgiapodcast.com/68 for all the links and the video. And now, my interview with Dr. Jessica Drummond. Welcome, Jessica. Thank you so much for being here. I am super excited to talk to you about this particular topic because I know I have a lot of clients that this affects. So thank you for being here.
Yes, thank you so much for having me. It's my pleasure.
Awesome. So today we're going to be talking about endometriosis. You've written a book about it. You've helped a lot of people with it. So I thought you were the perfect person to come talk with us. So let's just start with some of the basics. What is endometriosis for the people who are listening who have never even heard this word?
Yes. So endometriosis is one of the most common causes of chronic pelvic pain and infertility. It's essentially, I like to think of it as kind of a benign cancer. So with cancer, you get these lesions, these growths around various parts of your body. With endometriosis, it's similar. You have growths or lesions of tissue that is very similar to the tissue that exists inside of the uterus, which is called the endometrium, which is why it's called endometriosis. It's not exactly the same. And there used to be a theory that you were sort of menstruating out of the uterus in the wrong direction and sort of proliferating these cells. That's not true, but that was the original thought. That's where it thought these cells, these aberrant cells came from. So these aberrant cells, these like random, endometrial-like cells that are growing outside of the uterus can be anywhere in the body. They're most usually outside the uterus, around the ovaries, on the fallopian tubes, and some of the ligaments of the pelvis, on the colon, on the bladder, more abdominopelvic, sometimes on the diaphragm, but they can also be found on the lung. They can cause collapsed lung. They've been found inside the nose, on the knee. So they can be anywhere. And these lesions are metabolically active in and of themselves. So they have estrogen receptors, progesterone receptors. Sometimes they have excessive estrogen receptors, excessive progesterone receptors, sometimes both, sometimes neither. And because these are, wildly random lesions, the same woman could have all of these different kinds of lesions growing throughout her body, or just one kind. There can be more mild presentations with fewer lesions. There can be more severe presentations with more lesions, although the more severe is not necessarily more symptomatic and the less severe is not necessarily less symptomatic, because sometimes someone with fewer or even less metabolically active lesions have them in places that are more irritating, like on nerves or, around organs that move There can be adhesions, and it's also, so it's the underlying lesions. These lesions are active and they're inflammatory. So they generate their own inflammation, they generate their own hormones, and they respond to the environment, in the body as well. So they're exacerbated by general chronic inflammation. And there's some degree, like what exactly causes endometriosis is up for debate still, but it's likely to be some combination of genetic factors. So endometriosis lesions are found in almost the same percentage in female fetuses as they are in adults who have uteruses. So for adults with uteruses, it's 10%. For fetuses with uteruses, it's 9%. So these are present essentially at birth, but they don't become active until around puberty. Then we get the inflammatory component of the disease, and it has an autoimmune component and often presents with other autoimmune diseases like Hashimoto's or possibly fibromyalgia.
So is endometriosis considered an autoimmune condition? How is it categorized?
So by some people, sort of.
Yeah. Fibromyalgia is kind of the same way.
Yeah, I can't, that just sort of depends on who you ask, but I would say there is literature supporting the likelihood of endometriosis having some autoimmune components. For example, when a skilled excision surgery is done, where the lesions are actually cut out from the root, autoimmune markers decrease. And that improves pregnancy rates because there is a challenge of autoimmune infertility that often goes with endometriosis. So there's evidence that endometriosis has autoimmune components. I don't really know who's in charge of categorizing all of that.
Right, I know. I swear sometimes it's like the more we know, the more we realize we actually don't know. It sounds like this is one of those. So with there being so many different places this could be, ways that it's acting, how is somebody diagnosed with endometriosis?
Well, the only true way to diagnose endometriosis is surgically with a laparoscopic surgery by a skilled surgeon who can visualize, who knows where to look and can find the endometriosis. However, there can be a high index of suspicion if someone has had kind of digestive symptoms, digestive pain that begin pre-puberty, sometimes back pain, and around puberty, you'll get pelvic pain, cramping pain, pain down the legs, pain in the hips, which can be cyclical, although in pre-puberty and puberty, that's sometimes not the case. It can be random seeming or all the time. There is some hormonal component, usually later on in the progression of the disease into the 20s and 30s. As the cycle regulates, the symptoms tend to flare pre-period or right during periods. So there's a more cyclical nature, but that's not always the case. Sometimes it presents with painful symptoms anytime, just randomly, or even all the time. There's often an overlap with chronic bloating, which is probably small intestine bacterial growth, but it's colloquially known as endobelly. And there's a lot of fatigue and anxiety, depression, brain neurotransmitter challenges related to this, because when you're living in that level of pain, especially when it's unpredictable and it happens younger, it can be traumatic and can be associated with childhood traumas. And so, you end up having this cycle of brain-led, kind of brain-driven chronic inflammation. And then the lesions themselves are inflammatory, and then they can stick to things. So there can be issues of the colon being sticky, slow motility, constipation is very common, sometimes intermixed with bouts of diarrhea. So it's a layering of symptoms that develop over a time frame most often. Endometriosis can be silent, where people have no symptoms and never know they have it unless they have infertility. And it doesn't automatically go away with menopause. So while there is certainly some degree of estrogen or progesterone, depending on the person, irritating the lesions, once that estrogen level drops significantly, it doesn't necessarily turn off the endometriosis. And similarly, there are therapies, there are medications that suppress estrogen or put people into chemical menopause that sometimes help with the symptoms, because for some women, the increased estrogen does make the inflammation worse, but not always. So it's challenging because the presentations can be highly variable. But for me, the way I have a high index of suspicion of endo is if you see that history of things evolving pre-puberty, puberty, fertility challenges, and because there's this genetic component, that there's some story around that being common in the female relatives of the family, infertility, painful periods, and sometimes that makes it even harder to diagnose, because in the family, there can be this culture of, oh, welcome to womanhood. Everyone in this family has terrible, painful periods. That's normal. So sometimes it gets normalized even within the family. But now that there's more information about it, oftentimes mothers and grandmothers and aunts are realizing, oh gosh, I probably have endometriosis and you probably have it too. So the conversation is improving, but there's no blood test or definitive imaging. The only true definitive diagnosis is by laparoscopic surgery.
So kind of like a biopsy sort of a thing, or is it?
Yeah, exactly.
So a lot of what you described there is stuff that we deal with fibromyalgia, pain in various places, even the digestive stuff. So what are some of the key things that you might look for when it's endo, not fibro? Is it the part where it's related to puberty and your cycle? Or
yeah, I would say that to distinguish it from the chronic pain related to fibromyalgia, it would probably be more likely related to hormonal shifts. So cyclical, maybe not early on, but eventually. And there does not tend to be pain related specifically to endo for most people in places like the neck, the hand joints, the feet. It's mostly abdominal, pelvic, and there can be other areas, but usually it's not only in the knee or not only in the rib cage or the lung. Those might be far-flung places where endo can land, but you'll probably also see some abdominal pelvic presentation.
Got it. Perfect. Yeah, you talked about the neck and the shoulders, and that's a classic one for us. There's a lot of the fibro tender points are up in here, and Dr. Lipton, one of our fibro specialists, always talks about the traps of steel right here. So that's a good differentiator for people. So knowing that almost everybody listening to this podcast probably has fibromyalgia and is probably already dealing with pain and digestive issues and things like that, when would be a good time for them to think, oh, maybe this isn't just fibromyalgia and maybe I should talk to my doctor? And then what would those steps look like for them?
Yeah, so I think that my index of suspicion is higher if you have other autoimmune diseases as well. And again, fibromyalgia can, in many cases, fall into that category. And then there's really a pretty significant pain around the menstrual cycle for most people, and or painful sex, and or infertility. So those three more cardinal signs. And, you talk about the neck and shoulders. It's not so much a pain there, but sometimes there can be the pain of the neck and shoulders that is associated with dysautonomia. that can present in endometriosis, because there is sometimes an overlap with dysautonomia, which is challenges with blood pressure fluctuations and autonomic nervous system issues. I'm seeing that a little bit more recently, overlaid with our young college students who have gotten COVID when they went back to school. So it's starting to get even trickier in the context of that. So, I think this is one of those things where consistently follow up with your gynecologist, who may or may not be very well steeped in endometriosis, unfortunately, but cardinal signs of painful sex or pelvic pain, especially with digestive issues and especially with infertility, then I would recommend seeking a consultation from a skilled endometriosis excision surgeon. There are several throughout the United States. There's a center in Atlanta that will do a free chart review for you, the Center for Endometriosis Care. Out on the West Coast, Dr. Iris Orbach is a really good option. Cindy Mossbrecker up in the Pacific Northwest. In New York, Dr. Vidali. Massachusetts, Dr. McKenzie, who's, I believe, in one of the hospitals in Boston. So, on both coasts for sure. In Texas, there are a few good endometriosis surgeons. So it's useful to then talk to a person who does nothing but endometriosis surgery all day. Another place to start is to find a local pelvic floor physical therapist. They will often see a lot of endometriosis, especially if they've seen a lot of pelvic pain. And then it's really, is there a pattern recognition? We have a telehealth clinic as well. We do consultations, just kind of one-off consultations to see if we think you're landing in that endometriosis is likely category. And a lot of that's really just from the experience of hearing story after story after story. So I think our clinic, any experienced endometriosis surgeon or a pelvic health physical therapist who does lots of pelvic pain.
That's great. That's great. So to put this in some more real terms for people, could give them a little bit more of a clear picture. Do you have some client stories that you can share, like how somebody presented and then what they did to kind of address that?
Yeah. So one of our clients was in graduate school and she was really struggling with the pelvic pain. It was making her miss school, miss some tests. It was really kind of slowing down her program. And we do see that a lot. About 71% of women with endometriosis say that this has kind of derailed their career. And that makes sense because if you figure, it really presents in earnest between high school and graduate school. What if you're having the pain the day of your SAT or the day of your softball championships or the day of, grad school boards or whatever. So that's where she was. And the way we approach endometriosis is assessing each system and really lowering inflammation and calming the autonomic nervous system. So while this pain isn't in your head, it's true pain, absolutely. All pain is driven by the brain. And it's not just one message. So, when I went to graduate school, it was like, oh, you have these pain receptors. When you touch fire, you feel pain and you pull your hand away. It's really not that simple. There are a combination of signals that go into the brain called a neurotag. And that includes things like childhood trauma, fear of pain, family history of bad periods, your first period being laid out on the floor in 6th grade in a bathroom, and all of these things, right? A bad surgery, infertility, and all of those messages come together, not to mention the inflammation and actual physiologic biochemical symptoms of the disease come together in your brain and present those pain signals. So what we did with this client was we lowered the inflammation of the food plan. So we have a really anti-inflammatory, nutrient-rich food plan. let go of alcohol, dairy, sugar, things like that, soy, for at least 3 months, a sort of therapeutic diet to quiet the immune system, because as I said, this has an immune overlay, and calm inflammation. And then we really work on calming the autonomic nervous system. So lots of mindfulness practices, lots of breath work, lots of to activate the parasympathetic nervous system. Visceral physical therapy is another great way to activate the sympathetic nervous system. Things like craniosacral is kind of level 1 of visceral, and then there are lots of other techniques. Support for the gut microbiome and good gut motility. So things like chewing and good quality pooping and not eating while you're running around in your car, hydration, sleep quality is really important for endometriosis. Anyone who has a chronic condition really needs to be like in bed on the way to being asleep by 9:30 p.m. because we have this amazing window between 10 p.m. and 2 a.m. where the system in the brain, it's literally like a cleansing system called the glymphatic system, cleans up inflammation in the brain, which is really important because that helps the brain to release healing, pain lowering neurotransmitters and communicate healthy signals to the gut microbiome, improves digestion, and improves nervous immune system health. So deep sleep of 1.5 to 2 hours every night between 10 a.m. and 10 p.m. and 2 a.m. is really important. And of course, don't just get up at 2 a.m. Try to sleep a little bit longer for 8 hours. But that first part is really impactful. So we took her through kind of all of this lifestyle processes and even sort of reassessing her relationship with overworking. And she was under kind of a lot of stress. She was going to be getting married. They were moving, all of that kind of thing. But really, she did very well. We worked with her for about 6 or 8 months, and then she had a really good surgery. She was in good shape. She had the surgery, recovered quickly, and was able to graduate. She's actually since had a baby. She works full-time in her field. She's moved. She's happily married, and she keeps doing all the things that we supported her to do to keep her health optimized. And when you do it that way, when you have this period of preparation, 3 to 8 months prior to surgery, have a skilled surgery done where the lesions are removed from the root, and then a recovery period where you're focused on calming the nervous system, lowering inflammation, healing the digestive function, then the immune system heals, the hormones heal. We don't have to do a lot that just happens because most of these clients are in their mid 40s or younger. And so everything heals when the situation sets up for that. And it's not to say that the condition is cured, quote unquote, but the symptoms are very well managed. And, it doesn't become such a lifelong day-to-day struggle. But that commitment, that initial commitment takes roughly a year.
Right. To make sure your body's in a good place, have the surgery, do the recovery. So I've talked to so many people who have had multiple surgeries, like surgery after surgery after surgery, all for endometriosis. And I don't even know the question I want to ask you there, but is that typical, I guess? Was there something wrong with their surgery? Is it that the endo just keeps coming back and regrowing? What would that situation tell you?
Well, it depends. So when I first started doing this work, prior to the last 10 years, in my practice, I very commonly saw people with 16, 20 surgeries in a lifetime. And their pain management was horrible. They had nothing but opioids and stimulators and nerve stimulators. And PT was helpful, but only to a certain extent. Now, the surgical techniques have evolved a lot. And that's very important. The kind of surgery you get is important. You definitely want skilled excision surgery by someone who's not just delivering babies 85% of the time and then, oh, I do endo too. You want them to be immersed in endometriosis or similar kinds of surgeries, laparoscopic surgeries all day, every day. That's their job. But the other thing is that I think, well, that's important because even now there are people doing ablation surgery, which is just really not the right thing. But the other problem is even some of the best endosurgeons don't always integrate that whole year of healing, right? Physical therapy, nutrition, mindfulness, like taking out the lesions is one piece of the puzzle. But that's not the only pain driver. That's not the only symptom driver. And so we have to address this in a much more holistic manner to not have so many repeat surgeries. Now, that could still happen. I've seen someone who's had really good care, have to have a repeat surgery occasionally. The reason why for that is sometimes they don't get it all. It can kind of, quote unquote, grow back. Sometimes they didn't really see little microscopic endo that was festering. It can grow somewhere else. It can grow back. There is that genetic driver that we don't really know how to fully turn off necessarily. And the other thing that can happen is just because of the history of chronic inflammation and the surgery itself, there can be adhesions and inflammation that forms post-op. Just like if you had, say, a C-section or any other abdominal surgery, there can be post-op adhesions. And sometimes those are in really inconvenient places, like around the bowel, or an ovary is stuck to the back wall of the, pelvis or something like that. So that will then often be symptomatic as well. So, 1 to 2, maybe 3 at the very outside, if someone has a severe case, is the max number of surgeries I would want, anyone I knew to have to go through. But there would be a lot of work pre and post each surgery to really optimize health as much as possible.
Awesome. And is there I know you talked about your client that was in graduate school. Is there any sort of age range, right? Like, you need to be at least this old or at least this young.
To have the surgery, you mean?
Yeah. Yeah. Or even, I guess things like, managing your stress and eating well and getting good sleep are good for all of us, right?
Yeah.
But beyond that.
Yeah. And even pelvic physical therapy is a little bit invasive to that sense. So in a way, there's no too young age to start recognizing someone likely has endometriosis, especially if there's that strong family history or modest family history, and doing all of those things. Maybe not as much internal physical therapy work, internal vaginal or internal rectal, but support with digestive health, pelvic floor relaxation. In some younger girls, within that 8 to 12 range, internal pelvic physical therapy could be appropriate depending on, the rest of their history. And relatively younger surgery is better because that's preserving a fertility. So if someone is, say, 23 and has a really strong desire to get pregnant, even if her symptoms are well controlled, I might, strongly recommend definitely consulting with a surgeon, because a lot of times the work that we do can really calm down the symptoms quite significantly to where someone might think they may not need surgery, but the surgery itself improves the long-term fertility picture. So, and sooner the better for that, probably somewhere in the neighborhood of 17 to early 20s.
Okay. All right. And if somebody's listening to this in their 40s, 50s, is it still worth potential
Yes,
surgery and all of that?
it can be. So, assuming someone doesn't have fertility goals in their 40s or 50s, the conversation's a little bit different. So, endometriosis is quality of life threatening, but it's not directly life threatening. So, it isn't actually cancer. So, just because you have these lesions internally, if they're not bothering anything, if you have no symptoms that are bothering you, if your digestion's good, you don't have a lot of pain, then you don't have to have surgery. And there are some medications that can help control the pain in addition to physical therapy, nutrition, lifestyle medicine, supplementation. So in your 40s, 50s, 60s, even 30, even 20s, if you're not interested in having children, that's where the conversation becomes about a cost benefit situation for your goals, your health goals. And I definitely have clients of all ages who have chosen not to have surgery, and that's perfectly fine. And then others in their late 50s who did all the other things, but maybe their symptoms weren't as managed as they really wanted them to be. Surgery is a really good option.
Excellent. Excellent. So I know we're getting close to our time. So what I would love to do now is give our listeners some like next steps to take if this is resonating with them. I know a great next step would be to get your book. Do you want to
Yes.
share where people can grab a copy?
Yes, absolutely. So first thing would be to read the book. That details essentially our process that we utilize in the clinic. It's always evolving slightly, but it's a pretty strong demonstration of all the things that you can do pre and post surgery for recovery, or if you just don't do surgery, other things you can do. A lot of those really good quality surgeons and physical therapists that I mentioned are also listed in the book. So there's a lot of resources there. And you can get a free copy of the book at outsmartendo.com. And then from there, I would say, read that so that you're educated. And then, first of all, be very hopeful. This takes a bit of effort to overcome, but there are a lot of strategies for overcoming this. I think just like fibromyalgia, there can be this kind of idea that if you have this chronic condition, it's a life sentence. And that's not almost always true. I mean, sometimes it's very severe cases that really need to be more aggressively managed. But there's a lot that you can do that you probably haven't heard of yet. Most gynecologists are not very skilled with this. So as I said, step 2 would be to think about who's going to be on your team of providers, both to assess what's really going on here, skilled endometriosis surgeon, pelvic physical therapist. You can come through our clinic at integrativewomenshealthinstitute.com or send me a note on Instagram at Integrative Women's Health. And just find out, is this sort of what we're dealing with here? Is there anything else that needs to be ruled out? And then, have that confidence that there's a lot that can be done.
I love it. One of the things I always tell people is that fibromyalgia acts as an amplifier. So if you have anything else going on, like endometriosis or anything like that, fibromyalgia is going to take that and amplify your pain, your fatigue. So addressing these other things ultimately helps everything. It'll help lower your fibromyalgia because that's not there to be amplified. So please do take advantage of the resources that we're giving you here today. And let me give you the link for getting all of the goodies that Jessica was just talking about. It's just fibromyalgiapodcast.com/68 for today's episode. And we'll have the link where you can grab her book, the link for the clinic, and any other goodies that we come up with. Anything else you want to add here at the last minute? Anything that you want to make sure that people know?
Well, I think that's a really good point you made, that often people who struggle with these kinds of issues struggle with more than one. And the good news about the strategies in my book and everything that you teach is that a lot of the presentation of it, this very similar things helps to unwind both fibromyalgia and endometriosis and Hashimoto's and, right? So the good news is the work that you do, while it can feel like a little bit of a full-time job to be taking care of your health when you have one of these conditions, you're really optimizing all of your systems, which will help diminish the symptoms of all of these things because they very much can overlap.
Yep, definitely. Healing is a full-time job.
Yeah, certainly can be.
That was one of my big aha moments after I was diagnosed and I had to quit my job, and I just had this moment of, well, this is my job now. My job is to get better. And that can be tricky when you're trying to juggle being a mom, being a wife, having another job.
Absolutely. Yes, for sure.
All right. Well, thank you so much for being here and for sharing with us. Everyone who's listening, I hope this gives you some new things to check out. I know so often our doctors are like, oh, it's pain, it's fibromyalgia, but that's not always the case. And so I hope that this gave you some new things to check out and gave you some hope that maybe this is treatable too. All right. Thank you again so much, Jessica, for being here. And we'll see everybody back here in 2 weeks. And that wraps up another episode of the Fibromyalgia Podcast. If you're ready to see if working with a fibromyalgia coach can help you feel better faster, visit fibromyalgiapodcast.com, where you can schedule a complimentary consultation to explore your options. During this call, we'll discuss your fibromyalgia journey, what your needs and challenges are, and give you recommendations on how to reach your goals the quickest way possible. Thank you for tuning in today, and join us next time as we explore more ways to help you take back control of your life and health. My music and sound editing were done by Daniel Munkus at Subtle Soup Records. Podcast management and creative copy by Sonia Louise of Performance Podcasting.